Well,
Okay.
good morning.
Let's start courses, sir. Good morning, everyone. I, Dr. Anjana, on behalf of Pratiksha Academic Group, welcome each one of you. Due to ongoing COVID-19 pandemic, unfortunately, we have lost our seniors, colleagues, and junior doctors. Our sincere condolences to them, these COVID warriors, and their bereaved families. Good morning, everyone. In view of recent gruesome incident of assault on doctor and health worker at Hojai, I thank Indian Medical Association and Chief Minister of Assam for taking necessary action for the culprits. We are being hopeful. Today, after a month gap, we have assembled to continue our academic sessions. I am thankful to Dr. Devika Borua, who, in spite of her hectic schedule, has taken out her time to share her experiences and knowledge on today's topic, Principles of Microlaryngeal Surgery. I also thank Dr. Gautam Khan sir for agreeing to moderate the session. But before starting, I will start with a beautiful quote of learning. The beautiful thing about learning is that nobody can take it away from you. The expert in anything was once a beginner. Always walk through the life and as if you have something new to learn, and you will. Over to you, sir. Khan sir.
Thank you, Anjana. Good morning, everyone. And it's so nice to see that apart from the usual group that we today have a lot of people. Amit sir, Phukan sir is there, Dr. Mukherjee is there, Dr. Oheda Buragwah sir has also logged in. So welcome to each one of you. Our coordinator of the academic program, Dr. Anjana, has been doing a great job of arranging to have this meeting in spite of COVID, or whether it's COVID or no COVID. We are still having it regularly. We usually have it on the first Sunday, first Saturday of the month. Last month, of course, we had it on the next Saturday because of some other meeting which clashed with it. So today we have a discussion on microlaryngeal surgery by Dr. Devika Borua, who I can say is now gradually she will get the title of being the first laryngologist of Northeast India, dedicated laryngologist, because that has been her main sort of focus. And so I won't take much time. The larynx is, as I don't know who had said this, I forgot the person who said this. It is the most difficult instrument to play, and it's the most delicate instrument as well. So we should know how to handle this delicate instrument so it plays well. Over to Devika.
Thank you, sir, for that introduction. I am also, as Anjana Baidu said, in the beginning phase only. I'm learning, and I'm so happy to see all my seniors and respected teachers. So I'll just try to brush up the basics of microlaryngeal surgery principles. I'll just stop my video so that gets a better resolution while presenting. Can you see my screen?
Yes. That's right.
Okay. Just. Okay, so I have named the topic as Principles of Phonomicrosurgery, or microlaryngeal surgery also can be said. to introduce the subject, what is actually phonomicrosurgery? It's a surgery of the vocal folds that is done under high magnification with the aim of improvement and restoration of voice quality, vocal fold function, and vocal fold vibration. A history is actually very interesting. First phonosurgery was done by Dr. Victor von Barnes. He was actually a surgeon. He has there is so much literature about him about doing good work in plastic surgery also. In 1861, then microscope was actually to see the larynx, the vocal fold studied. Actually, it's began by Dr. Rosemary Albrecht. She was a German surgeon, and she actually used the gynecological colposcope to see the vocal folds. Supposedly, she did not get funds to develop the microscope properly, as Germany was in World War II phase at that time. Then it was perfected by Dr. Oscar Kleinsässer. And actually, he was a pathologist who got interested in ENT. Then he collaborated with Zeiss, and he made the first microscope. Then in side by side, modern era of direct laryngoscopy was started by Kirsten. Then improvisation done by many doctors, including earlier by Boyce and Jackson. Then suspension was added by Dr. Killian. And fine instruments were fine made by the guidance of Dr. Jacob. And till the 70s, mucosal stripping was done mostly, but the technique had very poor voice quality outcome, and it wasn't done with proper magnification and without the knowledge of physiology of vocal folds. Then Hirano came with the theory in the 70s. He came with the theory of body cover. That is, this is a superficial epithelium, then the basement membrane, then superficial lamina propria, then vocal ligament constituted of intermediate and the deep layers, and then comes the vocal muscles. He said the vibration is there in the vocal fold that prevents the injury, prevents the vocal folds from any injuries, and also it causes the normal proper voice what we have now. Because if we touch these two layers, then there are more fibroblasts in those layers. So if they are stimulated, there will be a scar formation after the surgery, and that causes poor voice quality outcome. So after this discovery, the stroboscopy allowed to see the normal vocal fold vibration, which is shown by the help of the stroboscopy, which is as described in the anatomy by Dr. Hirano. Then what are the equipments that we need for the microlaryngoscopy? This is an operating microscope. We have to take the 400 mm lens so that the long instrument handle can be, there should be at least 61 centimeter distance from the proximal end of the laryngoscope for the manipulation. Then the laryngoscope they used there are many laryngoscopes. This is the first one developed by Jackson, who had a sliding blade. He actually made it for the bronchoscopy, so that bronchoscope can be inserted to the through the vocal folds and the bronchial foreign body can be removed. And this is with then this is Jacko and Kleinsässer made this opening is wide in the distal end, so that anterior and posterior commissure both can be seen properly. So in case of more posterior work, this laryngoscope is more helpful. And then we know this anterior commissure laryngoscope, that is Hollinger. And there are others also like this Lindholm. Then comes the suspension system. Okay, then comes the suspension system. So first initial, the gallows system was discovered by Killian. Then actually we are not using these systems. We are mostly known the fulcrum rotation system. This is developed by Storch, then this is Louis, and this is a Boston University gallows suspension. It's forward and caudal pressure are given like this. And here in the fulcrum, we have, when we put the screw here, then there is a proximal pressure is also there, and anterior commissure is located very well. Yeah. Then the equipments are very essential. The other instruments are fine hand instruments. This picture shows the earlier cuff forceps where the mucosal stripping was done, or without proper magnification, just with the cuff forceps, the polyp or any other lesion is removed from the vocal fold. This was around 3-4 millimeter size or 4 to 5 millimeter size, but now it is 1 to 2 millimeter size cuff forceps are available. Cuff forceps may be right, left, straight, up, like that. Similarly, the scissors, up and angle, and curved scissors are also there. Some of the examples I have taken the photograph. This is a right turn scissor or left turn scissor. Then the crocodile forceps, and this is very useful. This is a triangular forceps known as Beauchère forceps to retract the vocal fold margin during the dissection. It's very delicate and it's very useful. The suction should be also very small. It's 3, 5, 7 French options. And there are so many instruments developed by different doctors whenever they have some discoveries made, like this straight knife or sickle knife, then spatulas like this, angled and blunt, like oval shaped, and then ballpoint straight, or maybe it's like hockey stick, but it's slender and slim, and it's more like otologic instruments which are longer. And pre-operative assessment for these before putting them for surgery in the any vocal fold lesion is very important. So I have it in books. It's mentioned that only stroboscopy should be done to see the proper vibration. But since most of the places still do not have the stroboscopy, I have just written oblique laryngoscopy also. At least we should see the lesion. So it's just a pre-op stroboscopy. There is a polyp. I have just muted the sound. This is a polyp. Is showing. You can see there is a less vibration on the over the surface of the polyp, but otherwise this cord is completely normal. We can see a normal vibration. Then medical issues should be taken. A history of any other, like any other surgery, hypertensive or diabetic or any other issues if the person is facing. And definitely the person should be off the anticoagulants and NSAID. There's a propensity of bleeding during the surgery. And history of radiation, if there is a neck position movement difficulty, because we have to put the person in specific position. So the flexibility of neck is very much required. Also jaw opening should be there. There should not be any lesion in the TM joint or any problem in the mouth opening. And there should be a detailed discussion about the procedure with the patient, since we should know the expectation of the patient, because some people are using their voice professionally, like for maybe singer, but maybe a person who works in a marketing area. It's not like that just after the surgery they will have to go, they can go back to their proper work schedule. Maybe it will take a month still till they talk properly in their workplace. Even if initial few period of absolute voice rest, then they have to follow the relative voice rest. Also, we should make them aware that it's maybe because of the vocal abuse they are having that lesion. It's not, there is even after surgery, if they do not follow the vocal hygiene, they do not avoid vocal abuse, do not take care of their voice, that might be a recurrent problem. So we should just inform them beforehand. And prior voice therapy and counseling about post-surgery sessions, if necessary in some cases, that must be also thought about. Like this case, this lady had a cyst and this posterior part of the right vocal fold, but along with that she has a muscle tension dysphonia type 2. So maybe that is also causing the voice more hoarse. So she needs to be counseled before the surgery, and there should be 3-4 sessions of voice therapy before the surgery. And after 3 weeks of surgery also, she will need the voice therapy sessions. Okay, and the actual surgery part, the anesthesia part is very important. Actually, the anesthesiologist should be experienced, or she should have some knowledge about the vocal fold lesion, because intubation is very important while going for these kinds of surgeries. There should not be any trauma to the lesions, delicate lesions in the vocal fold. And the endotracheal tube that should be used in this part, it should be as smallest possible size. In the books, it's mentioned it should be at least, it should be as small as 5 to 5.5. But our anesthesia give 6. I've seen up to 6 they have given endotracheal tube, depending upon the size of the lesion, and the volume of the balloon should be high, the pressure should be low, so that also should be kept in mind. And the patient should be in a proper relaxation phase. If there is slight flickering movement also during the surgical procedure, there might be some trauma to the vocal fold. So this is the position that we put the patient for the surgery. This is the actual actual picture from the book of Jackson, where he tried drawn several positions like normal, raised legs, faulty, this one. He tried different one, but he said this is the best one. This is we also known as Boyce-Jackson position, raised and extended. That is, neck is extended. Sorry, the head is extended, but neck is flexed. So this is the ideal position. And that head can be supported with a ring like this. So mouth guard is also very important. Just let me remove this. This is a mouth guard. This is a common mouth guard. We get it just made of acrylic, or dental implants also they make it. Or we can make it at our place also. Just make it. We put some adhesive tabs also over this and put it to prevent the maxillary part, alveolar ridge, which need to protect it. But in case of edentulous patient, it's difficult to put, so we can use some high density foam like this. So next step is after person is put under anesthesia, we are putting the mouth guard. All draping is done. The patient is covered, then we go with the laryngoscope advancement. Then this is a faulty technique. Sometimes when we push the laryngoscope blade like this, the non-dominant hand will retract the lower lip and the tongue. Then we go over the ventral surface of the tongue, reach the vallecula, then postpharyngeal wall, then we see the tip of the epiglottis. Then sometimes it gets pushed like this, so it becomes very difficult. Then there are some techniques mentioned in the books. So we can, with the other hand, we can hold the tube like this, or we can just follow the tube, endotracheal tube. And if we come to this part, like if we're going over the tracheal tube, we can just flick it towards the posterior part, and we can see the laryngeal inlet. And there is another thing mentioned. If the epiglottis is very floppy and then this method cannot be applied, then one cuff forceps may be introduced by the side of the laryngoscope, and we can hold it by the cuff forceps, the floppy epiglottis. Then the laryngoscope can be inserted easily. Then exposure of the laryngeal inlet. When we put the laryngoscope in place, we can see the inlet. Then we'll put the suspension like this. This is a fulcrum system. So suspension is there to put the scope in place, hold it steady, and it will, when we tighten the screw, it will further expose the anterior commissure. But we should keep in mind it will put pressure in the proximal, this maxillary teeth. So we should take care of that so that we don't injure that part. And also, if there is low visibility of the anterior commissure part, as Gustav Kilian is seen in this picture, he advised to give manual pressure like this with the fingers. We can ask an assistant or OT staff to put a finger there to the cricoid cartilage for the proper exposure of the anterior commissure part. But nowadays, it's also advocated to use a silk tape like this over the cricoid cartilage, so that puts a good pressure and the surgery can be done in proper view. And the posture of a surgeon is also very important. He should be comfortable, he or she should be comfortable while doing the surgery. The hands should be rested in a myotrelli, or some seats or some chairs are also available with hand support. So the hand should be put like this so that he is comfortable while doing the surgery. It can be microscopic, or nowadays we are using mostly VLS scopes with the endoscope in the, this is maybe taken in earlier photographs where people used to, for a better view, they used to take extra endoscopes via the laryngoscope without using the microscope. They used to do surgery like this. But right now the VLS scope, it's better, the incorporated, that's a 15 degree scopes are incorporated with the scope. So coming to the techniques, there are different techniques actually described. Some described as medial microflap, lateral microflap, but the basic idea is same. Prior superior lamina propria injections can be given. That may be with 1:1000 adrenaline. So that also elevates the this SLP. If there is too adherent, like early cancer, or there is a epithelial disease like leukoplakia, that should be excised by cold steel, then we have to elevate that flap. So that can be done. Also during in cases of sulcus vocalis, that is also very good to do. So that elevates the SLP, and that procedure can be done. Just to show you the basic idea, this is incise over the lesion with the blunt probe. It's all the size up, down, medial, lateral, all portions are removed. Then the lesion, the cyst is excised with the help of a scissor. But what is seen, even after doing microflap surgery, the patients are not satisfied sometimes. Maybe the people who use their voice in their profession, they are not satisfied with their voice, even after the lesion is removed. Then after that, Dr. Stephen Gray, he found that the basement membrane zone contains some collagen fibers. This is red one is the type 7, and this is the type 3 collagen. Type 7, they come from the basement membrane and return to the basement membrane. And this is from the SLP area they loop around the SLP, from the SLP to the basement membrane zone. While doing more dissection, even if it's a microflap, if you do more dissection, these fibers are disrupted. And when there is a healing, there is some scar formation is also always there. So that hampers in the normal vibration of the mucosal fold, and that leads to unsatisfactory voice. So keeping in that mind, mini microflap technique came into being. So mini microflap, they used to do just put an incision over the lesion only, and just mass is separated by the blunt dissection, or maybe scissors can also be used, as much less area as much as possible. Then it's held by the Boschaya forceps. Then it's cut at the base by the scissors. And there's always an extra piece of mucosa left because it is expanded by the lesion. So that can be left as an inferior pedicle flap, and that can be used as a biological dressing after the lesion is removed, and that helps in healing by primary intention. And if you disrupt too much mucosa, that will lead to healing by secondary intention, will stimulate the fibroblasts, and that will cause a scar formation. So this is just a clip I want to show. It's a mini microflap only. See, there is an incision made. It's a bigger polyp only, not a small one. Sorry. So we see there is an incision made. There was no injection given, so that's optional. You may not give an injection. So that's a pledget, cotton pledget soaked in 1:10,000 on epinephrine. That's very useful. You have to, then that's a blunt dissector going in. Just press it. Just needs a lot of patience also. And this is the Boschaya forceps. Holding this one. Then this is the angled, upturned angle scissor. There is an adequate extra mucosa that is excised as much as necessary only. Then we put the cotton pledget like this. It takes some time. We can also use an angle tip or fine tip electrocautery also to burn a bleeding vessel if there is any. But it is better if we do not use as much as possible. Sorry. So it takes a few minutes more, but we are trying to do without cautery as much as possible. This is an inferior flap that is put like a biological dressing. So it's done. So laser brings the same principle into being. Laser is also used now also in some benign lesion also. We have seen in many presentations people are using, though it's advocated more for the neoplastic lesions or early carcinoma, something like that. So this is a polyp. Actually the point of the laser should be here, just at the beginning of the, not at the base, because if we use that, so the area of destruction goes up to here. So there should be, there's a more area of destruction when you use the laser. So that should be kept in mind while doing surgeries with the laser. So now there are powered instruments are also used in case of lesions in the vocal fold. This is a microdebrider, which is used to trim the skimmer blade. There are different blades of the microdebrider. This is a skimmer blade, just trimming this lesion. And here also in the posterior part, it's used. And debulking a large tumor, it's very helpful to use a large triangular blade, then it trimmed with a smaller blade. It's a powered instrument. It has the advantages and disadvantages also. Advantages of large lesions, and it's done fast. It's very fast. Plus, but its a shaft is big, so introduce and manipulation might be difficult sometimes, even if the laryngeal instrument is available for that. But still, it's more useful for debulking a large lesions nowadays. And also we have seen a recent seminar also in coagulation is also coming a long way. Mainly in RRP also I've seen it's used mostly. So it says to be safer, but the general principles lies the same. As much as epithelial should be set at the epithelial part only. So postoperatively, topical lignocaine spray is applied just prior to extubation. So the patient does not cough or there should not be any laryngospasm while during extubation. And injectable steroids are given if there is too much manipulation in the vocal fold and the edema is expected that might cause some breathing difficulty. So just before extubating, we can give an IV steroid. And the first is tape should be removed properly because that puts a lot of pressure. So first that should be removed. Then the suspension and laryngoscope all should be removed very carefully by inspecting the oral cavity for looking out for any injuries. There are some complications. There might be some dental injury, and some patients do say about numbness in the tongue part. That causes a change in taste in some cases, but it's very temporary. Then delayed complications are there may be some, may not be some improvement of voice scar formation, or there might be some flap injury during the procedure. And if the flap is not placed properly, that might also lead to some other lesion. So post-operative advice is absolute and relative voice rest is also always there. There are confusing terms. Some people say it's 2 to 15 days, some say it's 3 to 30 days, but at least 72 hours to at least 48 hours absolute voice rest should be there. And after that, relative voice rest, as much as the person can do, at least after 1 month, I would say, relative voice rest should be there. And patient should be called for follow-up after that. And reflux prevention along with other adequate post-operative medications as necessary, like antibiotics and all. But reflux prevention is of utmost importance, plus adequate hydration. And voice therapy, like in this case, even after the surgery, as I discussed earlier, this person had a polyp on this left fold that I showed earlier in the stroboscopic video, but still he has some, because actually he did not have so much of muscle tension dysphonia before, but when he was asked to use his voice less, he went to speak in whispering voices, and that lead to the muscle tension. So the faulty practices should not be done. That also should be reminded to the patient. They should speak in a confidential voice, soft voice, but not in a whispering voice. So recent advances I have read only, there are some tissue generation or stem cell implantation researches are going on for some lesions, especially what are vocal scars and all. So maybe in near future we'll some new advances. So to conclude my seminar, I'll say the phonomicrosurgery reflects the combination of vocal fold surgery and the endoscopic guidance by applying the following the body cover theory. The aim is to get an optimal voice with maximal preservation of the layered structure, and healing should be promoted by primary intention. And laryngoscopes, there are many options are there. So the whichever is chosen, it should give you the best exposure. And the fine laryngeal instruments are the most essential, along with the adequate magnification. And postoperative follow-up advice and voice therapy are very much essential, so that we let the person know to prevent him. It does not matter. It may not be like he won't be having any more of these lesions. So all the vocal hygiene advices and prevention, we should let them know about it. These are my references. Thank you.
Thank you, Devika. I think it was very comprehensive. In half an hour, you have been able to compress everything together. Before we come to the queries in the chat box, there are certain things just I want to, Devika has mentioned it, I want to just stress. You have shown the various positions of the head, of the neck during for MLS. I just want to say that most of the time nowadays, we prefer to have the neutral position, where there is no flexion or extension of the neck, neither at the neck nor at the acanthooccipital joint. But if there is some degree of cervical spondylosis, or there is too much of an anterior larynx, we have to sort of change our positioning accordingly. Regarding the point about microflap, I remember when we had the phonosurgery conference way back, probably third or fourth in Delhi, people were doing lateral microflaps, and gradually, because of the excessive dissection, they changed over. Now we are doing only mini microflaps, as we have mentioned very correctly. Then the pressure on the cricoid, you have shown nicely on the diagram, but I want to stress for people who are doing it, because there is a tendency when you tell the assistant to press, they will press on the whole of the larynx. And that actually does not help. When you press on the cricoid, the larynx tilts, and when it tilts, you can see it better. And regarding, you can also use carbon dioxide laser. It's actually preferred to, burn the vessels rather than. And one point I think you should stress, you have mentioned, but you could have stressed, is about the pre-op counseling, because pre-op speech therapy and post-op speech therapy, there are many people who do it regularly. We don't do therapy regularly, but definitely that is something we need to counsel the patient, because there are certain times when people have to be put on therapy because they had, as you pointed out, about the additional muscle tension. Devika, let us now come on to the questions. So one point I wanted to mention, you have shown the anatomy very nicely, and in one of Satilov's book, he has written so nicely that, the lamina propria, it's a very supple sort of fluid filled tissue. Then gradually the vocal folds meet together anteriorly, and it forms the Broyles ligament and attaches to the larynx. But before it attaches, there is the anterior lamina flava, and posteriorly also, before it attaches to the arytenoid, you have the posterior lamina flava. This posterior and anterior lamina flava, actually, they contain less fibrocytes, and because of that, there is a gradual transition of the density of the vocal folds, so that the changeover from one density, because the movement will depend on the density of the tissues in the vocal fold. So because of that, the vocal fold, according to Sattloff, behaves like it is like a machine with a lot of ball bearings. So this is his comment, what I wanted to share. Devika, let us come to the chat.
Yes.
There are questions waiting for you.
Okay. Sir, just I want to mention one more point I forgot to mention during you said about the position of the patient. There is another thing mentioned, reverse Trendelenburg position is also preferred, because that is useful for the surgeon. So that also helps in the proper exposure of the larynx.
Devika, the first question, as expected, would be from Tukan sir, and Tukan sir has asked the difference between MLS and VLS.
So VLS is, we do it with the endoscope assisted, that is the video laryngeal surgery, because we see the monitor and we do it. And MLS is the with the microscope we do the surgery. That is the difference. And VLS is more preferred nowadays because the endoscope, the distal end, the visualization is much better than the microscope.
The actual role of SLP. Another question from him.
Actual role, it's a fluid filled space that helps in the vibration of the vocal fold. Anything else, sir, if you want to add?
No, I'm not asking the SLP, that anatomy SLP. I'm asking the person SLP.
Oh,
Speech language pathologist.
Speech and language
Oh,
pathologist.
Okay. Oh, that is the role, sir. I said previously, because some people might need pre and post of therapy. So they should be advised those. Sessions should be planned with the speech language pathologist. And some suppose there is an early vocal fold neoplastic lesion. So definitely after the surgery, the voice will not improve, but it will be worse. So for that also we need to counsel them and send to the SLP people also pre and post sessions are required. It's individual for the patients, different lesions, so different counselings and different therapy sessions.
Fukan sir also has this question about the 400 mm lens.
Okay.
Why is it the 400 used? Is it for the instrumentation or what?
It's also for instrumentation plus the focus. If we use 200, we have to take the microscope so near to the laryngoscope, we won't be able to do any dissection or anything. Any surgery won't be possible. So it's definite. It's mentioned in the Sakalov book only. It should be at least 61 centimeter from the proximal end of the laryngoscope to the microscope.
No, you have mentioned only instrument. Therefore, I have mentioned the FL, focal length.
No.
Otherwise,
Yeah, it's for the vision only, because it's not otologic. We can go to the near, so we use the 200 mm lens.
otology also, if we do 200 mm, because some people use 250 lens for the as you have told, for instrumentation. You get a gap also, 250 mm lens.
Yeah,
in
that is
otology.
why we'll have to take the scope so near. So I mean microscope so near, we won't be able to do anything.
But in some otology, if you take a Jolnas instrument, then I think 200 is sufficient. Not the 250 is necessary.
Otology for 200 is recommended for otologic surgeries.
Some people do it 250 for the Rosen's instruments.
Okay.
Fukan sir, the next question is also from you. Suturing of the incised gap.
Actually, that is advice for sulcus vocalis patients. That can be done by removing the flap, uplifting. That is, fat injection is put inside the sulcus. Then they used to do the suturing. But nowadays, people are changing that. Sometimes it's said that they do not do it. It's actually a surgeon preference. It's every day it's improving. So different discoveries are made every day.
Anjana Talukdar wants to know about when a patient has mouth opening problems like submucous fibrosis or maybe lockjaw, then what do we do?
Then we have to, if there is too much difficulty, if it has to be done, then you have to go for open surgery, because we cannot insert a scope. There is no point doing that. Or you can do a flexible, if there is an office procedure, if you can do in the person, that is an option with the flexible scope.
Absolutely. Kudu Samit sir has this query. Absolute voice rest was not advised as essential by some kind post-op period. Your take in what are the difficulties faced by a beginner? Two questions actually. First question is about your opinion regarding absolute voice rest. For how long, and your reasons of giving an absolute voice rest.
Absolute voice rest, sir, is actually, it's like any other system in the body, any other incision. We put a overdressing over that, but in the vocal folds we cannot put anything, any point to pressurize. So when we talk, the vocal folds will move. So vocal fold needs some rest. So ideally, initial part is definitely required. Otherwise, there will be the voice might be worse. There may be more edema, more congestion in the vocal cord. Already there was a surgery done. So I think it's a must, at least for 48 hours. The patient is given a notepad and a pen to write whatever they want to do. They can say by writing.
Okay. In between, lot of people used to advise that patient should be allowed very low voice speaking without raising the voice or whispering.
Okay. Yes, sir. That is relative voice rest. That is actually, I have seen many books. I have searched also for this seminar. Also, I have searched. At least 2 days are recommended by everyone. But some people go to the extent up to 5 days also. In Satlock book, because he does most of the professional, like opera singers also, he does surgery. So for them, he advises 5 days of absolute voice rest. So I don't know whether the common people that we are getting, maybe they do not follow that, but at least we try to make them follow 48 hours of voice rest.
Okay, thanks. Thank you.
Thank you.
The other part of Sir's question is that what are the difficulties faced by a beginner? I think Priyam has made a paper on that, which will be published in our FC journal. But Devika could say that. Or
in doing surgery, sir. You mean surgery?
Priyam can mention the difficult.
Yes, sir. First, sir, stability of your hands when you do the surgery with a long instrument and with the we holding the polyp, it shakes like anything. If you are going to hold the polyp, that is with practice, and you have to take some time. You have to have patience while doing surgery, because it's a small thing. We might feel we'll just cut it off. It should not be like this. We should take some time, and your hands should not shake while we do the procedure. That is the, I think I find that difficult when I do it.
Can I
make a comment?
Yes, sir.
Yes.
Actually, seeing the size of the lesion, you should not take a small time. Rather, as Devika said, take a big time, make it stable. Though you slightly said that a Mayo table is necessary for stability.
Yes, it's actually good to give rest to the surgeon's hands while doing
Yes, it will be better, I think.
Regarding your hand tremor, let me tell you two things. One is that because the instrument is long, a little tremor will reflect as a big wave at the area of your section. That is one point that you have more or less mentioned. But what I wanted to say is, when you are doing MLS surgery in a new setup with a new anesthetist, and maybe you are also new, you have to insist that the relaxation must be adequate. Because when you spend a lot of time lifting and exposing the larynx with your laryngoscope, by the time you actually come to the surgery, your hands are already strained. And that time you start getting the tremors. So having adequate and relaxation and using the instrument to just glide in without using excessive force actually is one of the key points, so that you don't get overstrain the muscles in your hand, because at the time of surgery you will have problems otherwise.
Can I give a comment here?
I think that's a good point.
Sir,
but for Satish Jain, it is necessary. He do the steppies after a havoc surgery.
He can again go and play cricket for the whole day after that. He is something different.
Superman.
Mukherjee sir has said that importance of anchoring fiber should be stressed during microflex technique. The importance of pre and post-op speech therapy has been rightly stated, and he has said it's a good presentation.
Sir. Thank you, sir.
And Oppo, I don't know who is Oppo 517, has said beautiful presentation, Devika. I think must be Abhidada, I don't know.
Thank you.
Anyway, there are no more queries, but we can have questions from anybody directly. There's no problem. I think we have got a little more time.
Sir, can I add a few technical points, if you allow me? Because I think there is 10 minutes.
Please do.
Regarding the MLS and VLS, sir, the lenses, now the new camera, new microscope, they have a varioscope system actually. It is not like 200 or 400. As Devika has said, at least optimal distance between your scope and the tip of your forceps should be 60 or 61 millimeter. But if that suffice, and you can have it do work 300, that's a varioscope system. Your focal length varies. So there's the beauty of the MLS system nowadays. And second is that if you, the endoscope, as Devika mentioned, using VLS system, it is a 15-degree scope, 4 mm, now Devika? That is a
Yes.
4 mm scope with a 15
Yes,
degree.
yes.
It is not a 0 degree.
No.
Second, now what we have learned actually from Nupur, to delineate the pathology, to document the pathology, she uses 5 mm scope if you have a laparoscopy system, so that you have more details of your pathology. And if you use it with a spice camera, so it gives the how vascular, if you in a Clara mode or Clara chroma mode, then you can know the vascularity of your pathology. In that way, as Sir has said, they can put the laser beam the vascular vessels.
It's in the, yeah, it's in the Sattler book also. Actually, to make it concise, I have left some of the part. He has mentioned what they do regularly in a polyp case, they inspect properly if there is any draining vessel or feeding vessel to the polyp also. They do a contact endoscopy also. Maybe that time it was spice and all was available when he wrote the book. What they do a contact endoscopy and they see if there is a feeding vessel to the polyp. And they will just do a cautery of the vessel or put a KTP laser also on that vessel to cauterize it. Or if the vessel is draining, they will not touch it. But the feeding vessel they used to, because to prevent, they think that is causing the recurrences.
Exactly. That's why you can on table demonstrate or on table discuss regarding the more details about the pathology. If you go to all these
and even though they are doing only microscope only, they maybe when they wrote the book, they did not have this VLS system. They used to keep 0, 30 and 70-degree endoscopes. So during the procedure, if the visualization is difficult, they will put the endoscope through the laryngoscope, they will see the lesion, then they will proceed with the surgery.
And another point, so for the beginners, most challenging is the introduction of your laryngoscope. And if it has a difficult area. So it's very important in the pre-op assessment, do a very good flexible stroke, so that you can know what is the status of the base of tongue, what is the position of the larynx. And if the mostly it's difficult for the anterior commissure or the anterior part of your vocal cord relations. And another important is the counseling regarding the teeth, if there's any kind of loose teeth. That also, and we nowadays there's Devika, so it's a stores most probably the tooth guard now. So what we do?
Tooth guard it's available anyways from the anesthesia people also. You can make also
and also the
dental implants also they make it. Dentists also make.
You can use a that's a technical point.
For edentulous patient, they have advised to use a foam, and then that is more useful because the implant does not fit also, but the foam will protect the gum. So its foam is very good to use.
Vishwajit is lucky to have a good microscope like Novena, which has got a varioscope, but most people who are not using such a high-end microscope will have to know about the lens definitely. But varioscope has got a great advantage. You can focus from anywhere, and so people with refractive errors have a lot of advantage with a varioscope microscope. And can I ask Priyam, because she had this her publication probably has been accepted for the journal of the Indian journal. She presented a paper also in the Kolkata Phonocon. If Priyam, you are around or if you are able to speak,
yes,
you can just enumerate
the
difficulties that you had faced as a beginner. Your paper was on difficulties as a beginner.
Yes, sir. Thank you, sir. So the most important thing for me was the introduction of the laryngoscope. Because I did a lot of
your voice is
in the first. So can you hear me now? Yeah. So apart from the regular problems that microdissection demands, I think as a beginner, I had a lot of problem with the laryngoscope insertion. It was difficult to keep up track of the teeth and the pillars and the endotracheal tube at the same time. But yes, I did a lot of anterior pillar tear-ups in the first few cases. And then it was very important to practice the laryngoscope insertion in different kind of patients, easy ones, difficult ones. So yes, starting from the teeth, there was a slippage of tooth guard during many cases. We forgot to keep track of that. So keeping track of the tooth guard in place, then for following the endotracheal tube, not putting too much pressure on the pillar by doing a very harsh insertion of the laryngoscope. Plus, a lot of problem was encountered in the hemostasis parts because we were not very confident with the electrocautery, and if we did use the electrocautery, it would result in a lot of scarring. So taking a part of the patients, using pellet, adrenaline pellet, normal saline pellet very regularly. It was a very tedious, but it was a very fulfilling part, because using a lot of cautery I did use in a patient, and then the post-operative picture was not very good to look at. So yes, it was a hard lesson to learn that way. Using micropellet, adrenaline soak micropellet to control the bleeding was a good lesson that I learned. Apart from that pre-operative assessment, I think we mismanaged in some of the patients because we did not take care of the neck scar. Horizontal neck scar is more dangerous than longitudinal neck scars. All these small things we used to learn the hard way possible. Patients with irradiated neck, sometimes they look good on the clinical table, but while they're sleeping, the extension becomes really difficult. Again, another point I would like to stress for the beginners, I think if you are doing multiple surgeries in a day, it's a very good idea to put the MLS or VLS at the top of the list. You do not want your hands to get fatigued by the time you start MLS and they already start trembling at the very onset. So I think Counselor also follows that rule. He always puts his MLS and VLS at the top of the OT list table. And apart from that, I think regular practice, even when you're not operating, maybe you're assisting a senior surgeon, we should try learning to introduce the scope in a harmless manner. Also, while taking out the scope, we do not, a lot of time we miss some of the pellet or some of the cotton swab that we used during the surgery. So making a count of that swab is very essential. One of the time it happened that my anesthetist, he actually found that while he was extubating the patient, and maybe he averted a major disaster that day because it could have easily been a foreign body bronchus or trachea. So taking care of that and taking care of the injuries if you have made any while coming out, explaining to the patient that these kind of precautions, these kind of problems you are going to encounter is very important. Pre-operative as well as post-operative part is equally important as the operative part. So.
Thank you, Priyam. Devika, would you like to add something?
Yes, she was just, I was thinking she was saying about the cotton pledget inside the, that is what the first, when we put the cotton strip, actually it should be strip like, and the silk is tagged. So when we put before the surgery, just focus it, and then we put the cotton patty just inferior to the vocal fold. So just the thread should be always there to keep us reminding that there is a pad, even if it is soaked because of the bleeding and all. When we do the surgery, if there's some angiomas and also or hemorrhagic fluid, there might be some bleeding also. So we just take it out before withdrawing the laryngoscope. That should be always kept in mind. Thank you.
Yeah, I think that is very important because
Yes,
these
sir.
neurosurgeons, they use these patties, and
Yes,
it is known as neurosurgical patties only.
Okay.
Because they were the ones who started this habit of using these tagged patties,
Yes,
so that they don't lose them.
Yes.
So also, sir, I would like to mention one thing. It has not happened to us, but I came across a literature that we need to keep track of the micro dissection instrument that we are using. Some very micro or old dissection instrument, if we have, they might rust off at the edges, and they might break off during the surgery, causing a very small.
Yes, I remember there was a paper by somebody.
Yes.
And in fact, you young people may not know, Abheddada had written a paper in our journal long time back, I don't remember, about the breakage, not in MLS, in probably tonsil or septal surgery, I forgot. He had mentioned about breakage, about quality of issue. Yes.
Yes.
So, Marcelda.
No, I want to tell that not that about the actually who is your guru. and how you have to learn. This is most important to put it in the laryngoscope.
Yeah.
And about this setup also. If you have got only one laryngoscope, then it will be difficult. And different larynx are very variable. Actually, I think that is the most master. And one small question, Devika, you got two
Yes, sir.
cases. One is
Okay.
hemorrhagic polyp, one is long-standing polyp.
Okay.
What is the difference of treatment?
Sir, hemorrhagic polyp depends on the duration and the size also. If the duration is short duration, we'll always do conservative management first, then we'll go for surgery. But nowadays, if the hemorrhagic polyp is sudden, but it is a big one, they advise to do surgery. Laser is preferred over the cold instrument uses. That is the current.
Why the immediate surgery of the polyp,
Uh,
the hemorrhagic polyp?
it is just actually we do not justify that, sir. Still, we always do conservative for 2 weeks and observe how is it if the size because sometimes with anti-inflammatory and all the size reduces. Even some polyps even disappear also with
Yes.
conservative
Why?
management.
Because Hokelas, I've seen many cases, if they come second time, no polyp is there,
Yes,
particularly
sir.
hemorrhagic
Yes,
polyp.
yes, definitely, sir. Conservative should always be preferred for benign lesions.
But
And
you are
Devika,
very fine, precise.
Yes.
Very good.
Devika,
Yes, sir.
you mentioned that in hemorrhagic polyp you can use laser, but if you have a
Laser,
carbon
yes.
dioxide laser, will be a very messy instrument to use in a vascular lesion.
Yes, sir. Sir,
Uh,
actually, we are just seeing some papers or some prominent surgeons of India are doing that, propagating that. So we are also in the phase of trying to understand why they are doing it. Even Counselor was
I'll
also
finish this and
mentioning
go.
a few days back about it.
Sir, if I
Yeah,
can
he's
come in,
finishing.
actually what they do, most of the surgeons, what they do is they just burn the feeding vessels
Yes.
with the CO2 laser.
Yes.
We actually put the the cautery around 15 or 17. Then we take a small shock. It is not on the vibrating edge, it is on the body. So that is why it has not happened that we had lot voice problems post-operatively, because we are not doing it. We are doing the cautery on the surface of the body of the vocal folds, not on the vibrating edge, just to cauterize the bleeding vessel.
So what about the coagulation? Use of with the MLW1.
I think that also can be done. It depends on the availability of. You can. Why not?
Can I just put in a word?
Yes, sir.
Hello. Actually, regarding laser, they say that the KTP laser lends itself very well in vascular lesions, and the reason for that is KTP is absorbed by the hemoglobin. Okay,
Okay.
and selective burning, almost selective burning occurs in where the blood is concerned. So KTP, and now KTP is a it has both contact as well as non-contact modes now. Originally it was contact mode. Uh, yeah, most of the KTPs earlier on used to be contact mode, where you have to operate with a fiber, like you do in the other laser that we used to have. Anyway, the thing is that you put it intralesionally. You put the tip of the fiber into the lesion and fire slowly. You'll see the the effect of the laser as you fire. Step by step. It is what is called as imploding. The size of the lesion will keep, if it is a vascular lesion, it will keep on reducing in size gradually, and ultimately, you can before it becomes totally gone, it becomes like an eschar, and you can just excise it around the margins. So carbon dioxide doesn't lend itself well to vascular lesions, because it has hardly any coagulating property. KTP has very good property. ND-YAG has, but ND-YAG is mostly used underwater,
Okay.
like in urology.
Thank you, sir. I remember you had this experience with KTP laser with Mikluz when he had this clinic. You had done a
Yes,
number
yes.
of cases with KTP laser.
We had done a few. We have vascular lesions, and it's almost miraculous to see those vascular lesions disappear. But unfortunately, KTP is very expensive, so very few people have it. Right? In the private setting, it's very difficult to get a. Yeah.
Thank you, sir.
Thank you.
If
Thank
there
you.
are no more queries, I can hand over the microphone to Anjana, our coordinator, for winding up the session.
Before that, I thank Devika and both moderator and speaker, but I like that my this initiation does not goes wrong. Bhupen Phukan from Tinsukia, so Kobit show ranking first now, and from Obhinav also came up, and from Tinsukia, Lakhimpur also. Why Anjana? She told me that don't give her any idea. No. Actually, it is.
No, sir.
If someone
Actually,
likes, he can join. No problem.
yes, sir. No. I discussed with Anjana Baidu actually. Now the mood is something different. Maybe may not like it. I just thought like that from myself.
No, just the mood, because if I've got some sufferings, my mood is not good, I may not join. This is okay.
Yes.
Nothing. This is about the participation, and people
Yes,
also
see
speak
this.
also feels nice. Moderator also feels nice.
Yes, sir.
Okay, Anjana, your part.
Thank you, sir. Thank you so much, sir. And I will request everybody to switch on the video so that we can take a pic. Whoever is there. Okay, thank you. And thank you, Dr. Devika. Thank you once again for your lucid presentation. And thank you, Gautam Khan, sir, for moderating the session and sharing your knowledge and experience as always. And thank you, S.B. Phukan, sir, always encouraging us. And also our senior doctor Kudus Ahmed, sir, Abedda Buragohai, sir, and Dr. S.N. Mukherjee, sir. And please, this one,
Bhupen Phukan.
If sorry if I miss out somebody's name.
Obhinav
And Abhinav also I have seen, and even Biswas sir also. And thank you, everybody. Thank you.